Since you're not metabolizing glucose to glycogen, as Ralph says, you're putting all this fat in the liver. Brian, tell us all about it.
Okay. So
Gordon will come back to you.
Oh, yeah. In some respects, it's talking about NASH and fatty liver and fibrosis. I was thinking, is the horse out of the barn? Because so many of the risk factors we've been talking about, it's, if someone's been obese for years, if someone's had diabetes for years. When I was at EASL in Vienna this past spring, all of the case studies in NASH were, a patient with type 2 diabetes for the last 20 plus years now presents with elevation in their liver enzymes, gets a FibroScan, which of course is measuring stiffness, and shows fibrosis. And it really begs the question of whether or not we're doing a good enough job in treating the underlying illnesses. And it's really easy in my space. So I was actually at FDA for a meeting this morning, so I can say as recently as this morning, there's so much focus on diagnosing a patient with NASH, so NASH being not only the fat in the liver, but the tissue inflammation, and then ultimately the scarring, the fibrosis, end-stage cirrhosis as a progression. But there's so much focus on how do we diagnose it. Do we do it non-invasively with an ultrasound, FibroScan type device, or do we do it with MRI? What algorithms do you use? What are you measuring? Or do you use the gold standard liver biopsy? Having trained in gastroenterology and hepatology at Johns Hopkins back in the 90s, I must say liver biopsy was my least favorite procedure, because taking a really big sharp needle and poking it into a highly vascular organ was not my idea of a good time. Would much rather do endoscopy. But the bottom line is, from a treatment patient standpoint, do we really need to be doing that? Well, yes, and under the current paradigm of getting drugs approved at FDA, we have to show that there's an impact if you want to get this NASH diagnosis and a NASH indication. And of course, you were saying a little bit about, why didn't they take the article to FDA and get it approved? I mean, so much of what we're talking about over these 2 days really cries out for a change in our healthcare system, because we have a system where drugs are paid for pretty much because there's an acute event and the drugs are there to treat it. And when you think about it, if you have a system where the drug cost is separate from the physician cost or their hospitalization cost, and the people who pay for the drugs don't get any savings, should you then prevent, we saw this with hepatitis C. They were curing patients in 8 weeks, and we've already seen the number of liver transplants go down, but the people who pay for the drugs, they're not the ones that necessarily pay for the liver transplant. So unless you're in a Kaiser or some sort of integrated healthcare system, the upfront costs aren't offset by the downstream benefits. And I think we would all agree from a public health standpoint, overall, if we aggressively treated A1C, hypercholesterolemia, LDL cholesterol, weight, we wouldn't then need to go and spend this money on NASH and the progression of NASH to cirrhosis, which in some patients ultimately leads to liver transplant, which is not only an incredible upfront cost, which has morbidity as well as mortality involved, but then a lifelong commitment to medicines, immunosuppressives, in order to prevent transplant. I do work with the Global Liver Institute, which is a patient advocacy group in Washington, D.C., and it was founded by Donna Cryer, who has just had her 25th anniversary of her liver transplant. She had sclerosing cholangitis. She didn't have NASH, but she ultimately went on to transplant, and now 25 years later, and she goes, I can only imagine the healthcare costs that have accumulated with the ultimate liver transplant, the medicines, the hospitalizations, et cetera. And can you imagine if we actually had an FDA-approved treatment for primary sclerosing cholangitis? That would be an incredible value to the healthcare system. But under Hatch-Waxman, which has been around since 1984, we have a system where companies are paid for innovation over the short term. They have to make their money, and then it goes generic. And of course, the day that the exclusivity and the patents all run out, there are 5 or 6 or 10 generics that come on the market, and the price plummets, and most of the innovators then get out of the market. Well, what does that mean for labels? Well, what it means for labels is that they don't change. It's only the innovator, only the owner of the drug, the original drug, has the ability to change the label. So if new data comes out and shows that a drug does amazing stuff for cardiovascular risk, and the innovator no longer is marketing the drug, none of the generic companies have the right to put that information on the label. Now, since 2009, there has been a guidance document saying you can distribute peer-reviewed publications and distribute the information, and we have, Dr. Google and the internet, and it's all out there. But it's not quite the same thing as saying, this is now FDA approved to do X, Y, and Z. So, for full disclosure, I did work for Orrin Hatch for a while. So I used to say we don't need Hatch-Waxman reform, we just need the Waxman reform, because the Hatch part was pretty good, which was the patent term restoration. But the bottom line is there's got to be a way for an ongoing incentive for a company to be involved with a drug in order to have the label evolve, to have a continued investment. And if over the years some of this new information comes out, there needs to be a way to perpetuate that. And plus, I think we're up to about 85% now of the drugs in the U.S. are generic. And ultimately, we're going to be in a position where most of our drugs are going to be sort of fixed label-wise. So as all of you are doing incredible things in prevention and finding new uses and new ways for drugs that are already on the market to help prevent aging and tackle these metabolic diseases, we won't get the full benefit unless we actually have a change in our FDA, healthcare, delivery system, et cetera. So I have no control over my slides. Oh, there we go. So this is just, this was NASH back in 2011, and all the things that the people here today care about are all on that list. The problem is if you go to an FDA meeting now, or if you're going to develop a drug now, the focus is on MRI. You do your proof of concept study, you do a dose ranging 2A with a couple of different doses, probably with an MRI endpoint just to try to look at fat, and then you go to a phase 2B trial, many of which are now 36 weeks, and they have a baseline biopsy with MRI and then a 36-week MRI with biopsy, and that gets your ticket to phase 3. And then now these phase 3 studies are well over 2,000 patients, and often the phase 3 endpoint, it's reduction in NASH or NASH resolution with no worsening of fibrosis, or improvement in fibrosis with no worsening in NASH based upon biopsy. 72 weeks, that gets you an accelerated approval, because that's not a definitive clinical endpoint, it's an intermediate clinical endpoint, which then means those patients have to roll over into a 5 to 7 year study where you actually look at all-cause mortality as well as hospitalizations, liver transplant, et cetera. So this is a long process to ultimately get drugs approved for NASH. And so one of the reasons why I'm such a big supporter of Zan's and his initiative is we need to do a better job, which is what you're all focused on, to try to prevent NASH and treat the underlying conditions that ultimately lead to it. So that's where I'm right now. Oops. So
why don't you skip to your horse?
Oh, so I was worried that the horse was out of the barn. And well, luckily in my backyard, the horses are still in the barn. So that's, so I think, the efforts of the group, of the folks here, are ultimately going to win the day. But we need to have a way that everybody is on their statin, they're getting their metformin, they're doing all the right things. And, it might start at page 18, because once they're no longer pediatrics, then that might be the way to go.